Thank you, Daniela, for the nice introduction, and also thank you to the organizers for inviting me here. And I was asked to discuss with you the anatomy of the rectum from the radiation oncologist's point of view. So for radiation oncologists, it's very important to adequately delineate the target, and it is becoming more and more important with the technical advances that we have available. So what you see here is how we used to treat our patients. This is a patient in the prone position, a posterior beam, and two lateral beams. And you can see here a very thin red line, and this is what we call the clinical target volume. So this includes the gross tumor and also the areas at risk for microscopic disease. And with this type of technique, it doesn't matter too much whether you delineate adequately or not, because you cover quite a big volume with your radiotherapy. But today we are using intensity modulated radiotherapy, and with intensity modulated radiotherapy we can get very steep dose gradients close to the target volume. And here again, the red line is the target volume, and here you see the intensity modulated beams, and you can see that you can very nicely cover the target and optimally spare the organs at risk around the target. But of course, if you here make a mistake in your delineation, you will miss the target. This is another example where we can also use an arc that rotates around the patient to deliver the radiotherapy. And here you see again very steep dose gradients around the target. And maybe the future will be protons. Protons are very specific with their Bragg peak, so you have almost no exit dose when you use protons, and you can even better spare the organs at risk. Do radiation oncologists delineate the target in a similar way? Well, this is a big question, because this is an example from the States where one CT scan was given to several radiation oncologists, and they were asked to delineate the CTV. And you can see there are huge differences between radiation oncologists when they delineate the clinical target volume. And of course, an error in the delineation means a systematic error for the rest of the treatment, so there is certainly room for improvement. And that is why we came up with guidelines on the definition and the delineation of the clinical target volume for rectal cancer. And when we came up with the guidelines, we started by defining the different pelvic subsites at risk for microscopic disease or macroscopic disease. And we defined 5 pelvic subsites: the mesorectal subsite, the lateral pelvic subsite, the posterior pelvic subsite, and the inferior pelvic subsite, and also the anterior pelvic subsite. We also defined 5 lymph node regions, and there is a similarity between the mesorectal subsite and the mesorectal lymph node region, and the lateral pelvic subsite and the lateral lymph node region. And then we defined 3 more lymph node regions: the external iliac lymph node region, the inguinal lymph node region, and the upward lymph node region. And these areas or subsites are at high risk for being involved by microscopic disease in rectal cancer. These areas are at low risk of involvement. So let's go into the high-risk locations for local failure. Let's start with the mesorectal subsite. So for the delineation guidelines, we defined the mesorectal subsite including the lymph node regions, cranially the level of the superior rectal artery, caudally where the levator ani muscle inserts the rectal wall, and the surgeon has shown very nice pictures on where this muscle is exactly located. And this mesorectal subsite includes the lymph nodes between the rectal wall and the mesorectal fascia. And on this CT scan, you can very nicely see, on this MR, sorry, the mesorectal fascia. And so this is how it is delineated. This is a coronal view of the mesorectal subsite. Here you see axial slices. This is the superior rectal artery. And when we go down, we can nicely delineate the mesorectal subsite using the mesorectal fascia as our guidance. And then we go down until where the levator muscle inserts. This mesorectal subsite should always be included in our clinical target volume. This is based on a literature review, and we see that in 1,347 patients, there is 46% risk of having positive lymph nodes in this mesorectal subsite. So clearly, if you want to go for pre-op chemoradiation or radiotherapy, this site should always be included in the clinical target volume. The lateral pelvic subsite we defined as follows. Cranially, the upper border is the bifurcation of the common iliac arteries. Caudally is the level where the obturator artery enters the obturator canal. Anteriorly, the border is the ureter, and it includes the lymph nodes along the pelvic wall, the internal iliac artery, the middle rectal artery, and the obturator artery. Here you see again the guidelines, common iliac arteries, then the lateral pelvic subsites. We go down, and then here the obturator artery enters the canal, and this is actually the anterior border. If we again look at the literature, we see that this area has a 13% risk of having positive lymph nodes, so it should be included in the CTV. And if we look at data on local recurrences, we see that this area is at risk of for a local recurrence. It's around 6%. So it should always be included in the clinical target volume. Of course, there is a relationship between the location of the tumor and the risk of a local recurrence. For the middle and height-seated tumors, this risk is only 5%. For the low-seated tumors, it's higher, it's 13%. And of course, there is also a relationship with T-stage. The more advanced the tumor, the higher the risk. What about the obturator site? There we suggest that we would only include these obturator nodes in the CTV if the tumor is located below 10 centimeters. And these are data from a surgeon who did extensive lymph node dissections, and we see from his series that the risk of having positive lymph nodes along the obturator artery in rectal cancer is around 9%. For the low-seated tumors, it gets lower the higher the tumor is located in the rectum. So that is why we suggest not to include the obturator lymph nodes in the CTV for a middle and height-seated tumor. The posterior pelvic subsite, this is the presacral space. It includes the lymph nodes along the sacral vessels and the inferior hypogastric plexus. It should also be included in the clinical target volume because if we look at literature, there is a 22% risk of local recurrence at that site. The inferior pelvic subsite, there is a lot of discussion ongoing, how we should delineate the inferior pelvic subsite, and you see here different delineations by expert radiation oncologists. Some of them say that we should include the fat around the muscle, others say that this does not make sense. Finally, we came up with a kind of agreement where we said that if the surgeon goes for an APR, we should include this fat in the ischiorectal fossa, and this was also nicely illustrated by the surgeon on how to do a nice APR without coning down. So for us radiation oncologists, we should follow what the surgeon does after the pre-op radiotherapy. So inferior pelvic subsite, always include in the clinical target volume if it is a low-seated tumor or when an APR is planned. For high-seated tumors, the risk of having a local recurrence in the inferior pelvic subsite is very low, so this subsite then should not be included in the CTV, and this has the extra advantage that some of the anal sphincter can be spared from radiation. So this is then for all patients, the clinical target volume should include the posterior pelvic subsite, the mesorectal pelvic subsite, and the lateral pelvic subsite, and then depending on the location of the tumor, the inferior pelvic subsite can be included, the obturator lymph nodes can be included, and in very rare cases, the clinical target volume is extended to the external iliac lymph nodes or to the inguinal lymph node region, but these are very rare tumors. Then this is the atlas that we developed. So you can here see the CT with the corresponding MR and the different structures that are used to define the borders around the clinical target volume. And this atlas is published and can be used and is used by radiation oncologists when they delineate the clinical target volume. When we defined the guidelines, we used the data from before the TME era. Now we can question whether in the TME era, when we have much better results, much less local recurrences, whether we still can use the same guidelines. And actually, if we look at data published on local recurrences in the TMA era, you see indeed that the anastomosis is still at high risk for local recurrence, the presacral site is still at high risk, as is the pelvic wall and the pelvic floor for the low-seated tumors. So based on these 33 local recurrences, we do not have to adapt the guidelines. This is a very extensive study from the Netherlands where they looked at TME patients, 5x5 and TME and extensive lymph node dissection, and they looked at the site of local recurrence. And here again we can state that we should not adapt the guidelines according to these results. The Dutch TME trial, they looked at the location of the 94 local recurrences. Here you see the dots are the local recurrences. These patients were treated with 5x5. These patients did not undergo radiotherapy. And then they made the difference between pre-op 5x5, no radiotherapy, circumferential resection margin negative or positive, And what you can see here is that if the circumferential resection margin is negative, you have very few local recurrences above S3. And also, if the patient is N0 at diagnosis, you have very few local recurrences higher up. And that is why the Dutch people suggest that we might be able to lower the upper limit of the clinical target volume in patients that have a negative circumferential resection margin or no mesorectal fascia involvement and that are node negative. So far, the delineation guidelines, it's nice to have these delineation guidelines, but how do they impact on the daily treatment or the daily delineation? And that is why we set up in Belgium a central review platform, and we connected 20 of the 25 radiation oncology centers we have in Belgium to a central review platform, and all their delineations were uploaded, centrally reviewed, and feedback was given to the centers before the start of treatment within 48 hours. So these are not only the centers participating in trials, these are all centers. We had 1,255 patients that were centrally reviewed, and we had 1,224 patients available for analysis. And so the contours were uploaded on the central server. They were reviewed by an expert radiation oncologist, corrected according to the guidelines. And here you see an example of an uploaded contour, and you see here part of the mesorectal fat was missed, so we corrected the contour and sent it back to the center. So these are the submitted clinical target volumes, and see what a high number of changes that were suggested by the central review platform. So although we have this atlas, although we distributed it to the centers, although we gave training to the radiation oncologist, there was still 74% of the delineations that needed a correction. Of course, we left it up to the center to accept the correction or not, because at the central review, we didn't see the patient, so we could not examine the patient. We only had the CT and the MR available, and that is why we left it to the treating physician to decide on to accept or not. But the majority of the changes were fully accepted, 37 were partly accepted, and 158 were rejected. Then we did analysis on the contours, and we looked at several parameters to compare contours, and I will now focus on the common contoured volume. This is the reference contour, this is the submitted contour. Ideally, these commonly contoured volumes should be 100%. And this is for the different patients in the study. So we made categorical patient order classes. So from 0 to 5 was order 1, from 5 to 10, 2, 10 to 15, 3. So this is what you see here, the class patient order. Here you see the VCC. Remember, it should be 100% in the ideal case. Look at the graph. First of all, important, our VCC was high from the start. This means that the training and the atlas is useful. So we start above 90%. But what we also saw was that there was a statistically significant learning curve for the first 10 patients in the different centers. And this is also interesting if we think about implementing quality assurance in big clinical trials. It's probably enough, for rectal cancer at least, to review the first 10 patients and then sample every 10 or every 20 patients. But it doesn't make much sense to continue to review because then there is no further learning curve. Now you can say, well, 74% changes, well, what does it mean? Are these important changes or are these minor changes? And so that's what we did then in the second part of the study. We did a 3D surface distance analysis to look at the importance of the changes and also to see whether we can adapt and clarify the guidelines to avoid the changes in the future. And here you see an example of a 3D surface analysis. This white contour is the submitted contour, the blue is the corrected contour, and so they are on top of each other. Green means a perfect agreement between the two contours, and then the color indicates the deviation between the two contours, and red means a 1 centimeter difference. And you can see here in the contour, at this side, there is a 1 centimeter difference between the two contours. And then we divided our clinical target volume in different regions, and then we looked at the number of modifications, and you can see at the high anterior region, apparently there is some disagreement between radiation oncologists, and we have up to 60% modifications there, and also in the high lateral region, we have up to 61% modifications. There is a very high agreement in the posterior region, so that's an easy region to delineate, and also in the obturator region. So our guidelines were very clear on how to delineate the obturator region. If we look at the changes, you see for the lower border there are changes up to 12 millimeters. That is because the disagreement on the ischiorectal fossa. You can see that here, it's almost 12.5 millimeters. And the lower border is also depending on the location of the primary tumor, the lower border is higher or lower. Very good agreement in the posterior region and in the obturator region with differences of 6 millimeters or less. So we can conclude from a 3D surface distance analysis that our results highlight ambiguities in the current delineation guidelines and stress the need for their further improvement, that more accurate delineation guidelines for the upper border and for the high anterior and high lateral regions will help to decrease the dose to the small bowel, and that the largest modifications are at the ischiorectal fossa, and they illustrate the lack of consensus on the inclusion of this region in the CTV. And so I hope that I stayed within my 20 minutes, and this is a very brief overview of what the anatomy of the rectum means for a radiation oncologist, and I would also like to acknowledge all the collaborators that contributed to this work. Thank you.